Yeah, forgot to get the background. Hi, Vijay.
Hi, good afternoon, sir.
Good afternoon. Good afternoon.
Hello and a very good day to all of us who have joined here from different parts of the globe. It is a privilege to be back here amongst all of you. 2.5 years into the pandemic, and we still continue to face shocks of different kinds and to various degrees. And the need for collaborative action continues to grow louder, and the noise that we are making to think that the world has come back to normal is yet a dream, but hopefully closer to reality. The Global Learning Collaborative for Health Systems Resilience was conceived a year ago in August of 2021 and was born around the time. 11th of March, after a 6 months gestation, it was launched. The GLC has grown, 40 plus members and technical advisors from 13 countries. The members come from diverse fields of health systems and bring with them rich theoretical and practical evidence and expertise. We have started this journey with the first theme on health systems resilience, with its definition and its assessment frameworks. Today marks an important part of the journey that we are looking to see how we have grown this thematic area. Before I call upon my colleagues to take forward the draft that they've put together, the systems framework that has come up, and seek valuable feedback on strengthening this piece of work, I would like to share the journey that we have gone through and the idea behind the core identity in a video that we are going to play for you. This will outline both the beginning of where we were and where we have come today in 6 months. Stuti? The sound didn't come through. And in order to make every nation safe, the GLC for HSR, as we call it, has traveled a journey, and we'd like to share with you the journey in brief of what has happened thus far. There's some problem with the voice, Stuti. Thank you very much. I now request Dr. Reddy to take forward the proceedings. Dr. Reddy needs no introduction to this audience, so I would directly hand over the session to him for him to take it forward.
Yeah, thanks, Uma, and good afternoon, everyone. Good morning and good evening for some of you who may be coming from different countries. Recently, we shared an annual progress update. It's 1 year after the conception and almost 6 months after the delivery of the GLC in March 11th. So based on the feedback that we got from the first P2P learning meeting, we have considered that suggestion that it can be more frequent but limited to 90-minute session, because the first session we clubbed 3 thematic areas of 90 minutes each. I think it was a bit prolonged for many of the audiences, and some of them could not complete the P2P learning session. So henceforth, I think we will have every month a P2P session. And we will be having the annual event on 11th March. So that, because that marks the launch of the GLC as well, and the declaration of the pandemic. So the calendar will be circulated to all the members. And once the thematic areas get crystallized, and also their journey plan is laid out, we can also mention which thematic area will be taken up in each of these sessions. I take this occasion to again rebrief the learning journey that we are undertaking. With each meeting and each event, with advice from the advisory members, expert advisory members, and also feedback from most of you, we have been crystallizing and fine-tuning this learning journey, and I think there is a reasonable clarity on the direction that this collaborative will be taking up as we go forward. As outlined earlier also, just I want to re-emphasize again, the learning journey, if we can talk in terms of the 5 Ps. The first P pertains to the knowledge pooling. It may be from the published literature, or it may be through the expert consultations or practitioners consultations, roundtable discussions. So this is the ongoing process of information compilation and pooling, which the technical team is processing to bring out certain concepts and learnings out of this information. So that is what the next piece, the processing. So this processed information, the team will try to present it in a way it addresses different stakeholders. And some of them are researchers, some of them are policymakers, some of them are practitioners, some of them are civil society organizations, private sector. So whatever the learnings will be formatted in a fashion that it is relevant and understood by different stakeholders. So that is the level of presentation. And some of these learnings will be taken into practice as pilots. So that is the fourth P, I would say, that it has to be translated into some of the pilots to demonstrate whether this learning is relevant or not. And these practices, if they're effective and efficient, they should lead to a better performance of the health systems. That is the end objective of the learning collaborative, that we make a difference in the performance of the health systems. Each one of you can actually partner and participate in each of these steps in the milestone, in the journey of the learning event. Some of you can be part of the literature reviews, systematic reviews. Some of them can also interview some of the consultants or give your feedbacks as blogs. So each of these information starts building up into the learning process. So that is the whole objective and the journey process. We invite, already a lot of people are partnering and participating in this collaborative as technical advisors, technical facilitators, coordinators, and volunteering to be experts. And also some of them will be called upon to review, for example, today's presentation, I think Maulik will convey that, to review the framework and give their expert opinions and suggestions. That's how I think we will start building up a rich consensus in deepening the concepts. As far as the thematic areas are concerned, I think the first thematic area, again, which will be taken up today, the overarching need to understand the very definition of resilience and also bring out a framework which can explain the resilience based on the various frameworks that have been already published prior to this meeting. But COVID also has demonstrated some of the lacunae in the existing frameworks, and a lot of expert suggestions were also considered in building a framework, I think, which Maulik will be presenting post this, my presentation. Once this health system level framework is agreed upon, there is an intent to deep dive into the health systems and its building blocks in the context of the 4 phases of the health shocks, how they have to be restructured, or how the functions have to be realigned for prevention, preparedness, response, and the recovery of health shocks. So again, I think these thematic works join back into the main thematic area of the overall health systems, the structuring. So this is the initial thought process of how to take this journey of the thematic process. I just took this occasion to re-emphasize. I think some of the new people will be joining, just to reorient on the learning journey process. Similarly, on the members process, some of you, I think, coming from different countries, we would like you to take and champion the GLC in your respective countries. We will be reaching out to you individually to be the conveners for the country chapters, because our intent is to slowly evolve, not only at a global level, a regional level, the national level, and subnational level, wherever it is possible, so that it becomes a culture of learning health systems. One of the means of transforming health systems is through the learning process. I think from the Indian tradition, we use the word Jnana Yoga to achieve the objective of the transformation. So just this is the brief recap on what has happened and what is likely to happen, both in terms of growing the GLC as well as what different roles each one of you can partner. Some of you might have already received letters inviting for interest in the next thematic areas of finance as well as the leadership and governance. There is already a special interest group formed for the ongoing thematic work on the surveillance. As more thematic areas will be taken up, including the supply chain resilience, the digital health for health systems resilience, and also the service provision, which is the most important thing. So we'll be getting in touch with all the members, inviting them to be part of this thematic journey right from the beginning by opting to be part of the special interest groups. And please volunteer to take up any component of this learning journey. I mean, the first thematic area, Access Health as the Secretariat, has put a lot of its technical inputs, but going forward, members should be much more active and take forward as a collaborative, which we will try to facilitate as much involvement as possible. With these few words, I hand over to Maulik to take up the actual the agenda for this today's session of the learning point. Over to you, Maulik.
Thank you very much, Dr. Reddy. And once again, warm welcome to all the colleagues out on this session. What I'm going to
Speak up. I think we lost Maulik. We just wait for him to come back. His audio seems to be a little trouble.
We have a power snag on and off in our office today, so apologies for that. So as I was sharing that, I think so what I intend to present today is the work that a team did, and as Dr. Reddy took us efforts of doing literature review, efforts of speaking to experts, both national and global experts, to understand two primary thing or answer to primary question. First, what do we mean by health system resilience? A term which has been used right from Ebola, but pandemic COVID has kind of brought it into forefront. And secondly, if we say it is resilience, what does it mean? One is definition and what it means in kind of actual implementation. So this is the effort that I'm trying to present. It's a work in progress. It's only sharing with colleagues, trying to get now a smaller group to kind of deep dive into it so that the group can own it. But this is what we intend to present today. Can we have the presentation, please?
Should I share your slides, Maulik? Anuradha here.
Yes, please.
Okay. Kindly let me know if the screen is visible.
Yeah, I think so. It's a separate presentation. We're seeing indicators presentation right now. Yeah, thank you, Anuradha. So can we go to the next slide, please? So when we started talking about health system resilience, so there were two main school of thoughts that were. One school of thought was of an opinion that health system resilience is an inherent characteristic where health system needs to kind of address to any calamities or a shock that the health system kind of encounters. There was another school of thought which talked that a resilient health system is that when there is a shock, when there is a hit to a health system, it starts learning, adapting, and then bouncing back to a particular state. And when we were talking to kind of experts and colleagues, we found it that they are not mutually exclusive. And based on that understanding, what we propose is that health system, what we define as a resilient health system, is a health system which has an ability to ensure access to high quality and affordable healthcare is safeguarded, guaranteed, irrespective of shock. So a shock cannot disrupt your provision of care. If the shock disturbs your provision of care or disturbs your access to affordable care, I think so that system needs to evolve. That's very important. And secondly, if shock happens, whether it was, I would take, I worked in HIV alone, so I take HIV as an example. In 2001, it was an economic crisis when people trans-border a movement of people infected with HIV was there. Similarly, COVID gave us a learning that how disruptive it could be for economy if people infected with COVID are moving out. But for me, if we haven't learned from HIV to what's happening in COVID, I think so your resilient health system needs to address that also. And that comes to the second part of the definition, that in order for the state to achieve a resilient health system, it needs to prepare during normalcy, it needs to absorb shock during crisis, transform and learn from the post-crisis. This is past crisis, the typology is a past crisis. So I think so a resilient health system for us as to define from what we have done and what we have understood is that a resilient health system is a constant kind of construct where your ability of your healthcare to deliver affordable, high quality care, safeguarding irrespective of shock. And in the process, it stays to learn and learn for us to do that. So this is what we understood from, and this is what we arrived after understanding this. What we did is that let's look at how people are next slide please, Anuradha. So when we started keeping this thing in perspective, Anuradha, can we have next slide, please? Yeah. So when we started looking with this perspective, we kind of did again literature review and kind of stuff. There were 6 or 7 main frameworks that emerged. We talked about resilient health system, which was disaster mitigation, checklist to improve health system resilience, UN Sendai framework, health system framework of WHO, city resilience. And the orange ones are those which those frameworks did not cover at the level. So we started looking at regulation and policy and at strata level in terms of international, national, subnational, and local. I think someone's mic is unmuted. Can we mute that? Thank you. So when we are talking about measuring what the current framework captures, we found that the current framework, we looked at both national, subnational, and local level. You see a lot of oranges, right? The oranges for us means that when we talk, let's take an example of organization of care. When we talk about organization of care, disaster mitigation framework does talk about organization of care at a subnational level. But the checklist to improve of health system resilience or UN Sendai framework or health system resilience or health system WHO health system framework or e-resilience framework does not talk about it. So for us, each and every framework had a value addition to the thought process of the construct of health system resilience. But obviously, the comprehensiveness in the way we thought that it should be addressed after any consultation and literature review was something that needs to kind of evolve. And based on that, Anuradha, if you can go to the framework slide, please. And based on both this assessment, what we propose is as follows, and it's a proposal because we need your inputs to finalize that. So by the time the slide comes up, for us, the thought process is as follows. When we talk about health system resilience, thanks Anuradha. When we talk about health system resilience and we talk about the final outcome, the centermost circle, which is health for all, and for us, the outcome indicators are accessible, quality, equitable, financial risk reduction, dignity, and improved health status. When we want these things to achieve from a health system, it can only happen when there is convergence, coordination, accountability, communication, and surveillance across 4 different strata of health system. And I'm using category this word strata. For us, the strata means that your health system gets defined at a localized level. Localized in Indian context, I would say a block, or we can use the word community out here, a local community. That local community again is a part of an ecosystem at a subnational level. In Indian context, it could be, let's say, a state. In Canada, it could be a province, or it could be a county. This all ecosystems are a part of the national ecosystem, and these all nations are part of the global ecosystem. So for us, when we talk about resilient health system, they can only be resilient when all these levels align with each other in provision of healthcare. But there are certain functions which are more important at the localized level, and it has got more significance at localized level. Certain function has got more significant at a subnational level. Certain function has got more significant at a national level, and certain function have got more significant at an international level in a global community context. And this is how the thought process behind the framework evolved. So when we started looking at deep dives in what are the important kind of health resilience functions that could be more localized level, it came upon that data collection for surveillance is a very, very localized function. You need to have as local information as possible, especially when you have got a new pandemic or new kind of infectious agent which is causing pandemic. Second thing, aligned with the communication access, the information, education, and communication, right? There are so many right and not right information flowing amongst community. Your IC level needs to happen at community level with community actors being actively involved. Your service delivery, certain portions are very localized, certain portions are subnational and national, but it is very important for your local community to be involved in provision of care. Your local community is also important in utilization of resources. Once the resources are made available, the role of community in appropriate utilization of resources is very, very important. And the most important part is local governance. And why we believe that all these important factors are more important at local? Because if I say that what kind of service delivery happens, the need of the requirement of services needs to come from the localized environment rather than top-down approach. It needs to be bottom-up. And in that bottom-up, when I say water, sanitation, hygiene, health, employment, everything contributes to health system or a health of an individual. And in that context, local governance becomes very, very important. And hence we believe that for resilient health system, the role of local community cannot be discounted. But now, as anyone would argue, that also results into duplication of efforts. So there needs to be a bit of standardization. There needs to be a bit of standards and guidelines that needs to emerge out of it, right? So who does that? So this about local community, we have this circle of subnational. In Indian context, I take state as a subject. Each state needs to have a data processing kind of functions embedded into it. each local community gathers data which feeds into a data platform, and a state needs to identify the way of processing it, which can be used for, again, decision-making purposes. Some functions needs to be aggregated at a state level, at a subnational level. Again, I give you an example. So if I need to buy medicines, if I buy medicines at let's say block level or at a community level, I lose an advantage of economies of scale, right? And at times in medicine parlance, rational use of medicines also gets discounted. In those functional contexts, it is very, very important that certain functions are done at a subnational level or at a state level. And those things needs to be aligned with the budgeting, purchasing, and fund distribution, which is mostly a top-down function. The local capacity of revenue generation is limited in context and in expansion. So at that time, that function needs to be harbored at a subnational level. Now, at a subnational level, it is very important to see there are multiple channels of funds that are going to come in. How do you prioritize based on the need of the community, and you make them align to the disbursement required? So I think so. This is again very, very important to look at in the resilience framework. How could be things done at a subnational level? Again, there needs to be a standardization. At local level, people are going to deliver services. People are going to collect IEC. People are going to do data collection. But to build capacity, you need to have standardized protocols and programs that could be done at a subnational level, which can lead a faster adoption and learning as far as resilience structure is concerned. But again, your subnational things are also fragmented. That harmonization can happen at a national level, where each and every nation prioritizes their health sector needs. In that context, a lot of policies, whether they are health policies or disaster related policies or human resource policies or commodity policies, those policies on which your systems are dependent on should be what be harbored at a national level. In again, a management function, we generally talk about new program management, right? NPM, where the decision making or the policy formulation function remains at the highest decision making authority, but the implementation arm should be at subnational and below the level of care. So here also we go with the same thought process. That a lot of guidelines, lot of things should be part of your national policies, but the delivery and those things needs to be at a subnational. But again, reinforcing on the fact that accountability, convergence, coordination, communication, and surveillance, they are integrated. So you need to do them in kind of sync. So let's say for standard treatment guidelines. So for standard treatment guidelines, if you've got the medications or biologics or vaccines which are approved by your federal government or a national government, the usage guidelines needs to be followed by the same entity. And hence for your standard treatment guidelines becomes a national function for certain products. Similarly, when we start talking about service delivery and planning, you need to create the structures, right? When there is inequity at a country level, a national level, or a subnational level, the role of national government in kind of bringing equity becomes very, very important. And in that context, certain service delivery function needs to be harbored at a national level. And we have a colleague, Jack out, I think so, in the group. And I think so, I generally like what Jack says there. The biggest tool to do that is breaking up the way financing works. So when you link your financing with line item budgets, you are constricting yourself in the way expenditure can be made. But when there are certain broad guidelines and a bucket of money is given, You give more flexibility in planning for delivery of care. And I think the national policies needs to do that. Research and development, which is very cost intensive and at times does not reap outcomes. And if you go to pharmaceutical companies' argument, for each and every innovative product that hits the market, the expenditure is around $1.2 billion. So if I just take that argument, I'm not saying that is right number or wrong number, but if it's a research and development is a very cost intensive kind of effort, those kind of cost centers needs to be borne at a national level. Funding, no doubt that within a country ecosystem, there is always going to be a friction between the needs of one sector versus other sector. Health would be competing with water and sanitation, with education, with infrastructure, to defense, etc., etc., etc. And at that time, a resilient health system are those systems where there are enough finances available to the health sector. And here I'm not, health sector means healthcare sector I'm not talking about water and sanitation. Even though water and sanitation has got input in kind of a big effort in kind of increasing the health outcomes, we need to take care of those things. And each and every nation, right, cannot work in isolation. Under globalization, national boundaries are blurred. If a country is affected, and COVID has taught us this lesson very, very well. So if, let's say, a country is affected by COVID, entire world got affected by COVID, because we are now a universe in itself. And in that cases, the international community needs to take responsibility of setting up international health regulations, setting up standard guidelines, setting up how international aid is gathered and flowed. The reason I'm saying is gathered and flowed because we know there are a lot of disease-specific initiatives, and we to get funds for disease-specific initiative. But when we talk about health system, the funding for health system is at much lower compared to disease-specific initiative. And at that time, the way international aid construct is there, we need to think about it. And for all this, we need international collaboration. The overlap between international health regulation and health policies, a classical example could be the way commodities are discussed in World Trade Organization, and human resources migration is not discussed in World Trade Organization. For us, for resilience, for countries to attain resilience, all this discourse needs to happen for benefiting both the community, subnational, national, and international level. And this is what we would like to present as the thought process on the framework for health system resilience. So I think so I have overshot my time, but we would like now to open the floor for reflections, and there are certain comments out here, so we can start looking into that. Stuti, are we
Not able to hear you, Maulik.
Maulik, you're frozen. Stuti, do you want to unfreeze the discussants?
hello?
Maulik, we can move on to the discussion of the framework. That's the next
Sure.
item on the agenda.
Sure, thank you.
Thank you.
So, as I said, colleagues, can we still display the framework side by side? So the colleagues, the floor is open to just cross-check us on the thought process that we have done so far. Again, there were certain kind of elements in chat box. Can we start looking at them?
Sure, Maulik. The questions of the colleagues are here. The first question is by Dr. Archisman from Grid Council, where he asks that, does this include the capacity for surge preparedness in the definition?
So Dr. Ashima, this is a very good question. And this was a feedback that we got from a couple of colleagues as well, that you need to have a surplus capacity to prepare for eventuality. Now, again, when we start talking about surplus capacity for search, is interpreted as search preparedness, one. And the other definition or other function in search preparedness is creating reserves. Now, when most of the countries are, and I'm talking about low and middle income countries and middle income countries, where there is a fiscal deficit issue, I think so, even though it is very important in terms of the financial resilience context, it needs to be studied deeper. And this is what we would like to deep dive into our financial resilience perspective. That let's say if you say you need to create for search, how you can make reserves to mitigate or respond to them. So Dennis mentioned, I think perhaps you need to ability to react quickly to changing situation like pandemic. Absolutely, and henceforth, Dennis, the role of local community income is very, very important out here, because what is needed at local community level is not understood many a times. And henceforth, those 4 bars we said, that communication, coordination, and when pandemic comes, the role of local community becomes very, very important. Second comment is the resilience might mean the healthcare system can react quickly to a dramatic change. Absolutely. So that word is very, very important. And again, so colleagues, for us, what we intend to do is now, based on this, we would like to construct a small group, right, which can further kind of refine this framework. Like Dennis, Jack comment, Ayushman is commenting, we can form a small group, we can further refine that framework, which could be then owned by the community, which we can start evolving and start writing towards it. So in this entire audience that we have, is it possible to get some interest developed so that we can a smaller group to further define this framework? You may just raise your hand, or if it is okay, we can share a kind of, we can add a technology somewhere in the framework. I know it's implicit, but so for us data processing, but yes. So Archimar, if it is okay, can you form a smaller group which can get into nuances about the framework and finalize towards it? Because as I said, it's a work in progress. Is there a possibility of doing that? Even raising hand or writing in a chat box would be helpful. So Archimar said yes. So there are questions from Anupama. Should we consider health for all or UHC? At the moment, we are focused on health for all. Universal health coverage, as you say, that definitionally is going much beyond health care. So at the moment, and because we have taken this lens of health system preparedness during pandemic era kind of shock, we are focused ourselves, but it's a very valuable suggestion, and we should, in the outcomes, as I said, we can get into a discussion in a small group to see whether we want an outcome indicator as UHC or health for all. Yes, resource reallocation capacity is emphasized as WHO, and so if there is something else that we are missing, colleagues, as I said, it's we are working on it. If you can add anything, if you can start owning, co-own this stuff, we can further refine it, co-create it, which can become a publication later on, which could be kind of presented to a larger kind of community. So Jack says that public financial management is key and was a failure in several countries. Amount is one issue, line is the second issue, and actual time is third issue. Fantastic, Jack. We should invite Helene Barrow and others. Okay. How can we define quickly? Can experts identify a timeline? Experts, we need to come together for that. I am not equipped for that. Focus on local communities. Thanks, Jack, for that. The higher and administrative change, the longer time spent in coordination meetings, agreement, and evidence. Yeah, so in pandemic preparedness, as Jack, I said earlier, it is very important for local community to get involved in decision making. And we need to have local community and subnational level, that coordination needs to be very, very aligned. And that is the key for any fast response in a shock. The word quickly, I would say, so that if the local community and the communication channel and the convergence between local community and subnational government is important, is there, it makes fantastic. So there is a comment from Sanjeev in a chat box. Can definition include public, private, and CSO-led healthcare systems as we draw pandemic the private? So thanks, Sanjeev. I think so. We should have made a point that this was any sector agnostic. So we are talking about public, private, both together, but it is very, very important, as you mentioned, to spell out private and CSO-led healthcare. So in governance framework, we would try to bring in the private sector component explicitly. But again, let's do it together. You know, we can do it. XSL can again take responsibility of doing it. But if you have got a group that can does it, have a couple of meetings together, it will become a work in progress faster.
Thank you so much. Thank you so much. Appreciate it.
So I think so. This is what we wanted to present today, and aligned to this thought process. Again, we will reach out to you with this framework. We will share this framework with you as something which is confidential, and we can start discussing. Once it gets finalized, as the group that's is present out here and other people who would kind of give comment virtually, will become the kind of owner of the authors of this, and we can start kind of socializing this at multiple platforms. And as Dr. Reddy said, that if there are other country colleagues, if they want to take this framework and test fire in their country settings, we'll be happy to support as much as possible. So with that, I would stop now, and I would hand it over back to Stuti. Thank you.
Yeah, thanks, Maulik. I believe, Anuradha, you want to go next with your presentation?
Thank you, Stuti. Kindly let me know if my screen is visible. There is a slight lag at my end due to internet issues.
Yeah, we can see your screen.
Thank you so much.
Thank you,
Thank you so much, Maulik, for putting this together and discussing that what's our journey been in creation of this framework. So what I will be discussing is what is the journey going to be henceforth. So first of all, against all these elements and sub-elements which Maulik discussed, we are defining certain indicator domains against which the indicators will be mapped. We'll also discuss the steps in the indicator mapping, and this particular exercise will be owned by each one of you, as Maulik and Dr. Reddy very rightly mentioned. I'll speak a little bit about the group formation, which Maulik slightly touched upon in his presentation. And finally, we have a very brief poll for all of you to give your viewpoints, and we are making a note of all the other questions also which are there in the chat, and we'll reach out to you. So just going back to the definition, there are, Maulik rightly said that there are two parts in this definition. The first is the definition per se, that the system should ensure that there is high quality and affordable healthcare, irrespective of the shock. Whether there is a shock or whether there is no shock, there should be a safeguarded healthcare provisioning to all of the people of a nation, of the world, of the region, etc. But in addition to that, the second part is what will help us to sort of look at how the indicators can be grouped. The first is during the normalcy. The second is during the shock, how the system is absorbing the shock. And finally, post-crisis, how it is transforming and how it is learning. So while we show the significant overlaps in the framework and we discuss that how different elements interact with each other, while developing the framework, we are bucketing this a little bit into some strata. Namely, there are 4 strata here. First is policies and regulation. Maulik spoke about the international health regulation, the international standards which are needed in a healthcare system per se. The second is organization of care. This is both an international but more of a localized function of how care is organized in a nation. The third is resources. Now, resources could be financial as well as they could be human resources, the digital health infrastructure per se for healthcare, and commodities, which includes drugs, supplies, and the other things which really drew our attention during COVID. So this is how we're looking at some of the indicator domains. Now, IHR and global health security are the 2 key areas in policy, but also the need for leadership and management, which was highlighted by our experts. Many of our experts whom we had interviewed are a part of this discussion, and we are grateful to them to sort of highlight this very important area. Then effective internal and external partnerships, which was discussed during the framework also. Policies and regulations, how the government regulates not just the health providers, but also beyond the purview of healthcare, how regulation plays a key role. Public-private engagement, which was perhaps one of the mainstay where private sector had to step up in a flailing health system as a result of COVID. And finally, risk planning. And it's not just risk planning, it's also communication of risk, how it happens. The second is organization of care. And we start with formation of these task forces. While there are a lot of elements of organization of care, but data flow is subject to formation of these task forces. Risk communication, as I mentioned, happens with risk planning. Research and development is sort of accelerated, which we saw during COVID, that research and development was accelerated, and that led to the vaccine being delivered to the whole world in such a short duration. Disaster SOPs, which evolved during such a crisis. Developing SDGs, not just for healthcare, but also to ensure that there is quality, there is reduction in vulnerability in the wake of a crisis. Maulik spoke about cost allocation, revenue shifting. But in addition to that, financial protection should be ensured even during crisis. The economic loss, which is extremely profound, is also another area we'd like to understand as we are mapping the indicators. And finally, on the non-financial resources, a key role which the human resource plays is task shifting, is capacity building, and to ensure that the health infrastructure standards are amended in the wake of a crisis. But digital health standards are also equally important with drug development and patient safety and dignity, which has been WHO's one of the key areas in the past few years. So these are some of the indicator domains we'd be looking at. This is our journey so far. With the green ones, the elements which we have completed, the yellow is in progress, and the orange ones, which we are likely to do with your support and your cooperation in the future. So the literature review and the expert interviews have been conducted. They have helped us to create the frameworks, elements, and the indicator domains, which will help us to pool the indicators. This is actually one of the first brainstorming sessions. This P2P learning workshop will actually enable us to start creating the indicators, and we'd reach out to you for more such interactions. And we thank you all for saying in the chat box that you'd like to be a part of this. Following that, we intend to provide some weightage to the indicators. Now, a system could be very well performing, could be medium performing, or would need to go into transition. So we'd like to see that how a resilient health system is performing and how that can be sort of given a ranking. And that would also enable cross-learning between different nations. Finally, these indicators would be tested, and we do country-level pilot studies. You all come from different countries, and we hope that we could do some cross-country learning based on that. This is something which Maulik started discussing. Hello? Okay. This is something which Maulik started discussing, that we'd be reaching out to you. There will be a poll after this particular session. In addition to that, those members who could not be a part of this discussion, they will also be reached out to. And we'll form a working group for the finalization of this framework, as well as the finalization of the indicators. And finally, we'll test these indicators. There'll be a lot of improvisation. We know that a lot of good suggestions have already been made, and we'll keep that in mind while we're developing the indicators as well. And as a group, that is something we intend to take forward. So with this thought process, I sort of end this presentation. This is probably something we intend to do in the future, and I thought we could discuss that. We have a very small poll for all of you. Just to get your thoughts, even among those members who could not express their thoughts, we launched this poll to get your thoughts. So kindly let me know when the poll is launched. You could probably just give a thumbs up. Can anybody suggest if the first question is launched?
Yeah, we can see it.
I need you. We'll give it a few more seconds.
Anuradha, what is next?
Is the question visible to everybody?
Yes, Anuradha.
So the question is that would you like to be a part of the framework validator or indicator validation? And if so, we would reach out to you to understand that which are the areas you'd like to participate in.
We'll need to proceed, Anuradha.
So 81% of the colleagues have answered as yes. So we'd reach out to you accordingly. So the last question is essentially about, can you suggest 5 countries where this framework can be tested? And that is for us to understand which of the countries each of the colleague could focus on. Kindly let me know if the poll is visible. Thank you, Uma. Please let me know when should I end the poll. I'll probably do that.
I think you're ready to end. Give it half a minute more and you're ready
Yeah.
to.
We have only 2 answers. So I'll just wait for half a minute more and I'll end the poll then.
Yeah, go for it.
Okay, so just as a follow-up, the same questions will be sent to you via a Google form also. And we'd hope that we could get the responses of the colleagues who could not answer the poll. So thank you so much. Over to you, Uma. Before Uma, Maulik, would you have any concluding remarks?
So thank you very much, colleagues, for your inputs. We know that in internet space, we are not in the best performance today. But what we intend to do as next steps, the group that's the colleagues who have participated today, we will reach out to you with a follow-up email, as Anuradha said, sharing us 2 things: the framework that we have done, the description of the framework that we are envisaging to write based on understanding, and then we will seek your time. We will make a doodle poll to seek a time once again for us to come together and further refine it and make a joint product, which can be a product of our global learning collaborative for health system resilience. In the process, if you want to invite other colleagues or other members who think they can contribute or they are willing to contribute, we'll be more than happy to actively involve them. So that's one thing. Second thing that we would like to seek your guidance is that once the framework gets ready, I think so, it needs to go beyond the group of colleagues that are working. So if there are any opportunities as shared earlier where we can present it to a different a set of colleagues, or we can present it into any kind of platform, uh, and where we are agnostic to who presented as far as any colleague from the Global Learning Collaborative, we'll be happy to facilitate that as we move forward. So these are two kind of steps that we believe that we will take forward. If there are any other suggestions, we'll be happy to hear on evolving this particular theme. We'll wait for the response. If not, then we can hand it over to Uma for her remarks. Thank you.
Dr. Reddy, would you want to have begin the discussion? And if anybody else would want to join in, please.
Yeah, thanks, Uma and Maulik. I think I see a lot of experts in the audience. I would love to have them comment because the chats are not as effective as actual comments. So I would like Stefan to make his initial remarks on the approach so far and the next steps and the suggestions from his side. Stefan, from you.
Oh, well, thank you, Dr. Reddy. Thank you. I guess I would say, I mean, the value of any framework, of course, is its utility, right? So you've got a very comprehensive framework. I don't think anybody's gonna is gonna push back. People always like to dicker with these, right, and add more fields or domains. But I do think that the last question you asked, and the thing that becomes kind of interesting and germane here, given the longer term notion that preparing for the next thing is really quite paramount and is on people's minds, is the question of what audiences you have in terms of not just national ministries of health. I see a comment on the G20. But you have ministries of finance, you have a lot of universities in the region who I think are very interested in helping think through what is actually necessary for the future. And that the framework can be a kind of a broad organizing tool. I think the value of presenting and discussing with a range of Asian stakeholders who have something at stake here, right? They don't want a repeat of what's occurred with COVID. Is that they may also help you, in a sense, simplify or strip down your framework, right? I mean, I think that would be part of the goal here. Is if everything is important, kind of nothing is important, right? That's always the danger. And given countries that have capabilities to take on a limited number of sort of significant reforms in certain areas, right? Whether those be about financing, about coordination, about governance, about rebuilding or improving a public health system or other. If the framework and the use of it is kind of a best case framework, it's going to be hard to people to deal with. But two things could be helpful: something stripped down, or something sequenced. Right? If you give people options around, you do A first, and A might be different by country or even a regional framework, right? Because remember, these are transmissible diseases. And if you can get A in better shape, then you kind of move on to B, right? Whether that be basic public health, improved lab functions, better surveillance, et cetera, et cetera. So let me pause there. I mean, I think it's really, really interesting, but I think always the challenge with these things is translation from framework to use. And I think this is where deploying this with a number of interested and informed parties, not only from the health sector, but possibly finance or others, could be really useful to get a sense from them of, well, how would they actually use this? Thank you.
Thanks, Stefan. I think always highly useful comments and suggestions. I also notice, I think Reda is there from WHO. She was part of the panel last time. Welcome to give your opinions on this. I think she might have dropped out.
Dr. Eddie Dawn is there.
I do see Reda is there logged in.
Okay.
Uh,
Yeah, Reda is there.
Maybe she has to unmute. Okay.
Yeah.
Yeah, Dawn, would you like to make any comments and suggestions from your side?
Don Prisoner, right? I'm the only Don here. Is that me?
Yeah, you are.
Oh, okay. Yes. Very interesting initial work. I think it's an impressive framework. I do love frameworks. Being an editor-in-chief and researcher, I always ask everyone to make frameworks because it's easier to project to the population. And for me, frameworks is sort of a representation of a theory, and population and researchers can always go back to the framework to test their data. So for example, the way I would see it, if you come up with a framework, we test it by looking at country data and if it properly fits. So it's like coming up with a theory. So in coming up with a theory in research, you start with the data and you develop a framework. When the framework is there, you now test the framework with different settings if it is applicable. So now you use the data on the ground and then try to fit it to the framework. So if we see that it fits in different settings, then therefore the framework is very good. It's robust, and therefore it can be used for other situations. So that's the way. That's why I love coming up with frameworks. But I do agree with what the previous person commented on, that it can be dissected first into phases until it becomes a general framework, because it's like snowballing. You start with something and then you add up little by little. But it's also, it can be done in different ways. You can test it, or you can have a general framework at once and then test it little by little and then do innovations on it. That's the way I look at it. Congratulations, very good work.
Thanks, Don. I did see Jack commenting on the chat box, but Jack, would you like to make comments?
Dr. Reddy, thank you very much. I don't have much to add. I've given my my comments in the chat. I think this is excellent work. You're off to a very good start. So yeah, I think the first two commenters made excellent points. I personally think that the heroes of the last pandemic were at the local level. And to the extent that you can further dissect at the local level how to mobilize and how to deliver, I think that would be very, very useful. That would be more difficult, of course, because that information is much more fragmented. But nevertheless, you might, if you have the resources, you might, when you do these studies, as the previous commenter has suggested, and I agree with that, you might want to go a little deeper on what actually happened at the local level. Let me stop there. Thanks again. Congratulations. Over.
Yeah, thanks, Jack. In fact, that is the intent of piloting and validating this framework at 4 levels. I think that's what Maulik agrees with me, that what is relevant at a local level, right from household to the local government level. And the next is subnational level, the national level, and the global level. I think so. As you rightly said, some of the elements are relevant at a global level, some are at national level, some at subnational level. So these need to be tested at a different level. The second thing is what is practical indicators. I mean, because each country may not have the capacities to identify or collect the data. So one way of looking at it is what data is available and what information it actually provides as an indicator. So that's, yeah, it is a work in progress, as Jack has mentioned. And also as the sub-themes are starting from this main framework, there may be a deeper dialogue in each of these sub-themes, especially the three core functions of the health systems in terms of the provisioning, financing, and the governance. More importantly, the governance aspect of it, because the previous UHC has focused mostly on the financing and provisioning, ignoring some of the other elements of the health systems, both structures and the functions. So I think as we go forward, other thematic areas will delve deeper into some of these aspects which are being commented upon just now. I do see, I think, some more people in the audience. Professor Deepak Raut, Professor Shamana is there, and Professor Vijay Eldandi is there. Please raise your hands. Dennis is there. Dennis, good to see you again in the audience here. Welcome. A comment from your side.
Thank you very much, Dr. Reddy, and it's great to see us all after COVID. It's been a long time.
Yeah.
And since this is the first time I've been able to attend your briefings, I would like to give you my reaction. What kept going back in the back of my mind, I guess I'm a marketer at heart. It is, what is the impact that we're hoping for from this study? Who are we trying to get to? Who are we trying to influence? What kind of change are we trying to precipitate? I think the world knows that because of COVID, we've been tested a lot. And question 3 on the poll kind of gets to that question. So now that we've gone through the test, what can we tell the world about how we can do it better? And I think in order to do that, we have to have a very streamlined framework, one that appeals to visual learners. If we're going after people like your Ministry of Health and Family Welfare, we need to be able to see where we can have influence in their thinking process. I'll just stop by saying, I know we're going to do thematic areas, but I think the framework maybe underestimates the role of digital health. It's mentioned gratuitously a couple of times, but I'm sure you know by now that I would give a strong recommendation that we think of innovation and how it can be used more carefully in the next round, in the next century, when the next 100-year pandemic comes along. And so I just wanted to share with you my sort of visceral reactions to what I've seen so far. As Jack said, I think it's a very interesting start, and it's very thought-provoking, and it's really a pleasure to be able to work with you all. Thanks.
Yeah, Dennis, I think we'll be seeing you Sunday. Maybe we'll catch up on what's happening on this. Any further comments? We invited people. If there are no.
So there is Ruby from Chesty over here. I would like to ask if she has anything to say. And Vijay has his hands up.
Right. Yeah.
Yuvi, would you want to say anything?
Yeah, really a great conference, and I think that I really don't have too much to add other than I would echo this comment that one of the things that we need to factor in is how we recruit the right kinds of decision makers who have the ability to control resource application.
because I think they need to be involved in this discussion a little bit more than has been to date. One thing that concerns me, and I'll tell you a small anecdote. Recently, in the state of Telangana, we had a crisis there. We had a lot of young women who lost their lives. And it wasn't clear to me that the right kind of expertise was available to the relevant agencies that would respond to that crisis in a rational manner. Maybe I'm being a little too judgmental, but that I think is, part of our dialogue needs to be establishing a relationship with key decision makers so that they understand what kind of process and framework we use.
Yeah, thanks, Vijay. I think, one of the objective is how do we disseminate some of these dialogues to the relevant policymakers. Sometimes it's the private sector leadership, sometimes it is the civil society leadership. So this is just the beginning in terms of once there is a collaborative consensus of some of these thought processes. The next step is how do we actually disseminate this learning to the right people. Unless it reaches the right people, as you rightly said, it does not create an impact, the desired impact which the GLC is expecting. Thanks for the comment. Next, Maulik, your hand is raised. You wanted to make a comment, or
Follow up Ajit. So Ajit has a hands raised. So Ajit, and then I'll just say something.
Ajit, over to you.
Yeah, thanks, Dr. Krishna and Maulik for this excellent presentation. I think Access is really on the right track. And as you're aware that I've been working with this urban health grant from USAID as well, where we're trying to work on urban resilience in Indore. And based on our understanding or whatever work we've been able to do till now, what we have realized is that social determinants of health also become a very important factor in health systems resilience. And so I don't know how we could also throw light or incorporate that when we are developing the framework. I think that would be important. And the other important thing again is, and you've already included governance and all those, which are really critical. But I feel the role of the private sector again here, the public-private, how exactly are we going to balance it? So I think that would need to be addressed. And the final thing is again, based on our COVID experience, what we've actually all observed and seen is that urban areas have been disproportionately affected. We've seen higher number of cases as well as admissions and mortality in urban areas as compared to rural. So when it comes to health systems resilience, how is it really going to be in urban vis-a-vis the rural? So I think that again would be some critical elements to look at. So I'm sure that once these groups are formed and we take these conversations forward, there would definitely be additional inputs coming on these areas as well. But I would like to congratulate the entire team for taking on this very important initiative, and happy to be a part of any of the groups and help in taking this forward. Thank you so much, Dr. Reddy.
Thanks, Ajit. Over to you, Maulik.
So thank you, my colleagues, for fantastic comments and observations. So a submission, I think a lot of things like Dennis did mention about on digital health and representation and private sector, Ajit mentioned, and previously also colleague mentioned about private sector. So these are very, very important kind of things that we need to kind of include into it. What the framework, the descriptive framework obviously has its and Don will agree with its limitation. So when we these things are captured in our write-up, so we would like your critical appraisal of the write-up as well, because as Dennis said, visually at times things appear different and the text might be on a different platform. So when the group comes together after we share the framework and write-up, your critical appraisal during the reviewing that write-up would be very, very helpful. And all points, thank you very much for giving those salient points, because it gives us thought. And Ajit, for your kind of social determinants, our aftermost access does talk about social determinants of health. So the only challenge we had is that the debate of social determinants versus healthcare, and I think so. When we come as a group together, we will kind of deep dive, because then the positioning of a lot of factors do get changed based on that clarity. So thank you for that.
Thanks, Maulik. Reda, over to you.
Well, thank you very much, and apologies, I had to multitask a bit. But thank you. Yeah, really happy to be part of this session again, and congratulations to the colleagues for all the, I think, the great work that's going into developing the various materials for this. I just want to highlight the aspect of looking at resilience also from the perspective of routine, day-to-day health system strengthening, even before or outside the context of a crisis. Because I think, as we know, health system resilience is usually, a big deal, and very popular when there is already an emergency. But if that same level of attention is required to strengthen the health system on a day-to-day basis, so that it has the public health capacities that it needs to identify and tackle the population health needs and tackle on a day-to-day basis. That way, the resilience is not tied to when there is an emergency, but it's being developed on a day-to-day basis, so that the health system is able to even prevent and manage small scale events before they become large scale events. And I'm also happy to see that the need for dedicated indicators for measuring health systems resilience. This is also a need that we have identified in our support to countries, and which is we're also working together, building on the health system resilience toolkit to identify to address that need. So I think we also agree on that gap, and it will be good to see how we can work together towards that. And thank you very much. I think I'll stop there.
Yeah, thanks, Reda. I think that is the premise that the strong health systems is the baseline. Which are supposed to be designed to meet the normal time requirement. But what is inserting by the concept of resilience is that the same health system should be able to rise to the occasion during a health crisis. So, yeah, the points I think well taken, and ongoing dialogue around this. The conventional indicators of strong health systems, I mean, how do they now shift if they were to meet the crisis situations? I mean, our all benchmarks in terms of the human resources required, in terms of the supply chains required. In the normal times, we have laid down the indicators, but we haven't laid down the indicators what happens when there is a surge. So that's, I think, the whole attempt at the new indicators is that we redefine the indicators by themselves, that they will be able to meet the crisis situations. So thanks again.
We have Dr. Grace also as part of the colleague group. So Grace, any feedback from you?
Hello, can you hear me?
Yes.
Yes, please.
Good afternoon, everyone. Thank you so much for the presentations, and to congratulate you on the work. The framework covers at least some of the things that we've discussed bilaterally. I just wanted to emphasize what some of the other speakers have spoken about, that is the role of the community level. And I think the need for institutionalizing mechanisms, not just for coordination, but for generating information in a in real time. And as we spoke earlier, this should capture some of the social and cultural nuances peculiar to communities. That is something that, at least within the Africa region, but I'm sure would also be relevant in Southeast Asia, can affect how a response, how effective a response to any shock, whether intrinsic or extrinsic to the system, is in terms of the effectiveness of the measures and uptake. And so some sort of evidence base that needs to be generated. And I think here the social the social sciences people come in very handy, whereby we're able to get a sense of the social dynamics that operate within communities that can have an impact on the effectiveness of pandemic resource. So I think that is something that I would like to add to the table that I think can improve the framework. Over. Thank you.
Yeah, thanks, Grace. I think some of those comments will be incorporated. When the team shares the narrative around the framework and the background information that was gathered in building this up, I think we invite much more open comments so that slowly we evolve a broad consensus around some of these thought processes. And once that consensus is there, then the next level is how do we test these frameworks in a practical situation? I think that is where we can invite the volunteers from this group or even outside of this group to test out at a local level or a subnational level some of these frameworks. And as I think some of the commentators mentioned, evolve some institutional systems to put the right mechanisms in place. With these few comments, I think we are towards the end of the session. Over to you, Uma, for towards the concluding remarks.
Thank you, Dr. Reddy. And I would like to place on record the group's valuable time and comments that actually make this a very rich discussion. Things that came out very strongly were the bottoms-up approach needs to be there, the cross-functionality of the structure that goes from the district to the state level to the subnational and the national level, the definite indicators and domains that were there, and the functional aspects of each of the frameworks that were presented, that were done in great detail by both Maulik and Anuradha. Some of those valuable thoughts and suggestions that we received from the group, the peer group that has given us this valuable and rich discussion, is translation of the framework to use, and looking at social determinants of health from other sectors, theories that need to test the data and how does that fit, impact, influence, and what does it change and how are we trying to change it, the digitization and what it can do to affect this entire resilience, discussions for decision makers and how should those be curated, the role of the private sector and the public-private partnership approach that needs to be taken, and the routine health system strengthening that is also a very important part, not just the surge strengthening that we are going to look at. So while we have all of you here, we had participation from Bangladesh, Indonesia, Thailand, Europe, Americas, and that came together only because this is a global collaborative. We look forward to your continued thought process and your approach to make this a successful collaborative that will bring forward frameworks and implementation as we go forward. Thank you. Good evening, good night, and good morning.
Thank you.
Thank you.
Thank you.
Thank you.